to I opened my practice in 1960, and I joined practice actually just to have experience with some other physicians. We just shared expenses. I was in practice with sharing expenses with an endocrinologist. I think I've talked about him before, Larry Kahana, one of the most brilliant people I've ever known. And then the cardiology, Bill Hopkins, his father had been a general practitioner here in Tampa. He went to Harvard. And then also my cousin married Bill, married Lawrence. And so she was in practice for a while, but then she went to work for the one of the government agencies. And so when I first got started, of course, it was a learning practice for me. And I learned a lot from patients as time went on. And I ended up knowing my patients like I knew my own family. I mean, I would spend a lot of time getting to know them as individuals. And I would usually spend about 30 minutes on the first visit to get to know them. And then on subsequent visits, they were often 15 minutes, but they could run over 30 minutes sometimes. And so as time went on, I learned more and more about their personalities, their medical problems, and so forth. And I was in the age of beepers. We, of course, in 1960, we didn't have computer, we didn't have cell phones and so forth, but we carried beepers with us that we could be beeped at any time, you know, when there was a problem. And if a patient one of my patients had a problem, they could beep me, and I would respond, or I would tell them, well, could you call back a little bit later, and so forth. So I was always available, but we arranged with the group and another doctor that wasn't in our particular group, Frank Nassari, who was a general internist. We arranged to cover our practices on weekends so that we could have some time off, and we rotated this. But before we changed, we would talk to that physician and tell them, the one that was going to be covering the weekend, we told them, well, we had a few problem patients, and told them a little bit about them, so they had a little bit of a background. But they had, in essence, they had medical coverage. We didn't have 911 in those days. I call 911 Dr. 911, because what happens is the physician's offices, they don't answer the phone anymore. They say, if this is emergency, call 911. And so I call it Dr. 911, because what happens when a patient calls 911, it's a recorded voice and says, well, if you feel this is an emergency, go to the emergency room. And so that increases the cost of medicine and results sometimes in not really good medical care. There's no follow-up. And so I had really gotten to know the patients pretty well as individuals, and it gave them a sense of confidence as well. And so I did do a lot of pioneer work in Tampa. I was interested in learning new techniques and so forth. And I did an intestinal biopsy. I bought an instrument that could be passed down into the small intestine. No one else in Tampa was doing that. I was able to diagnose a rather important person that had been living in the Caribbean, and no one had been able to make his diagnosis. It turned out that he had celiac disease that I was able to diagnose with pathological confidence. So I got to know the patients well, and they were like my family. In fact, as time went on, I developed a patient library for them. I had a special room, and I would buy different books on diabetes, etc., that were basically written for the layman, or that a layman could get some knowledge out of, and they could go in and read, pick out a book in the library that might be pertinent to them, if they so much chose to do so. I did not allow any pamphlets to be distributed in my reception room. That was no religious pamphlets, no pharmaceutical pamphlet. I did not want advertising in my reception room. So it was. I also made a film. I had a film made of myself doing an endoscopy, so that they could know, someone that they knew how the procedure was going to go and what was necessary. We didn't use, when we first started, we didn't use general anesthesia. That really wasn't available in a way. We would give the patient often some IV Valium and one of the veins on the arm, and that not always, but usually it gave them some degree of sedation and comfort in the procedure. Also explain what the procedure was about, so that they would be more relaxed in that regard. So that was some of the things I got involved with. And then I also, I should mention that before we had fiber optic endoscopy in Tampa, I had fiber optic scopes. I had to buy myself, because the hospitals didn't know what they were, and they wouldn't agree to buy them. So it was Olympus Corporation, a Japanese firm, that took over really the sales of fiber optic instruments. And I had the first salesman for Olympus for endoscopy, and there was one man that covered the entire United States as a salesman at that time. And so he said, "You're the first that I'm delivering a fiber optic instrument in Florida. There's no one else that has done that so far." And so I wanted to invite him to lunch after he went over the equipment with me. And he said, no, I'll be going to Colorado, and then I go to some other state and so forth. And so now sales representatives for Olympus for endoscopy, I guess they have maybe 4 to 5 salespeople just for the state of Florida. So that has changed a lot. And I might say that before we had fiber optic endoscopy, the most common instrument that gastroenterologists used was a sigmoidoscope. That was a rigid metal tube that could be passed and examining the left side of the abdomen, the sigmoid colon, where really most of the important pathology occurred. And I would do the scoping, the sigmoidoscope, in the office. I could do it without anesthesia. It took me a few minutes to do the examination, but naturally it was limited. That couldn't do what fiber optics could do. So in addition to all of that, I got interested in teaching. I love to teach. And so what is not well known in Tampa medical history is that before the University of South Florida opened their medical school, we had at Tampa General, we had 3 years of a certified program where students that want to get their MD degree could come for instruction. And that was started by my companion, Larry Kahana. And I was asked to teach. And that was a great experience for me. Some funny things happened along the well. I'll skip that for the time being. But then, of course, as time went on, um, there was more and more knowledge being acquired in the field of medicine. And so one physician couldn't really handle it all well. And so there began to be increasing specialization. And we used to joke about, in ophthalmology, what happened, the different layers. There's the retina specialist. I go to a retina specialist these days because I have dry form macular degeneration. And then there was the vitreous humor and the external conjunctiva and so forth. I'll tell you a funny story about that, just to show comparison of how costs have changed in medicine over a period of time. One of the most famous physicians in medical history was a man from a small town in Canada, William Osher. He later went to England, to Oxford, and became Sir William Osher. But at any rate, he practiced for a while in the late 1890s. He practiced in his little village, and he recorded the first patient that he saw. It was a speck in the eye, and he removed it with a little swab, and his charge was 50 cents. Well, of course, sometime, I forget the exact date, sometime in 1965 or 1970, I think it's probably 1970, I got a speck in my eye, and I tried to wash it out, and I tried to get it out with a little swab, and I couldn't do it. So I said, well, I'm going to this ophthalmologist that specializes only in the external eye. And so I went to see him, and he got a little cotton swab and got out the speck. And his charge for that was $250. So just to give you an example of how over a period of time, medical fees began to increase. And then, of course, what happened is that, I used to read a lot of, I love to read a lot, and because I was the only child, and I learned to read when I was about 6, and I love to acquire a large library, too large, in books all my life. And so I was interested in, I would read about 4 to 5 medical journals every week. On Thursday, I was not a golfer, and so I would go to the medical library at St. Joseph's, which was located in the basement, and I would spend the day reading the different medical journals. And I particularly like the British Medical Journal and Lancet, because they also would have articles about different social aspects of the practice of medicine in a way. But there was an article, I think it was probably in Lancet or British Medical Journal, around the 1950s. And it said, the title of the article was "The Death of the Professor of Medicine." Well, as I read the article, what it was about was pointing out that one doctor can't know it all anymore because of the rapid increase in knowledge and the development of computer use, so forth. And so that had to be recognized, that there wouldn't be one single professor that knew everything. So at any rate, I had to get used to using a computer. I'm very slow at that because of my background and years when we were just in a beeper, what I call a beeper society in medicine. And that was a slow learning process. In fact, I'm still having some problems with it, even in retirement. And so there were a lot of things that happened that were not well recognized in Tampa medicine at that time. We had some very good physicians in Tampa, and we had some really quack doctors. To give you an example, there was one doctor that would withdraw a pint of blood from the patient, and he would irradiate it, and then he would kill all the germs, of course, and then he would transfuse that pint of blood back into the patient's blood supply. I mean, really incredible. And I could give other examples of how far up, but there were some very good physicians in Tampa, probably in the minority. So I got to know all of the physicians at that time because there weren't that many. And I would say if someone said they were seeing a doctor, and if I didn't know the name, I'd say, well, it has to be a chiropractor or something, because I knew all the doctors in Tampa, almost all. And of course, as things grew, that I couldn't make that statement. But and then I went to mainly Tampa General Hospital, because my office was right across the street from the hospital, and I could just walk there at lunchtime and see some patients. And I also went to St. Joseph's Hospital, and the original St. Joseph's Hospital was in another location than what is now. It was very small. It was located off of Palm Avenue, and I had a bad experience there. I had a patient that developed, he had a gastric ulcer and began to hemorrhage, and he needed a blood transfusion. So I requested that they get him typed and get some blood in, because he was hemorrhaging quite a bit, and his blood kind of dropped down pretty low. And so they said, well, we have no way of doing this, because we have to get all the blood transfusion, all the blood transfusions transferred from Tampa General area. And so I said, well, I don't care how you have to do it, but get it in here. Well, it happened to be at the time of Gasparilla, and so they couldn't come through the crowd and so forth. And I waited at the bedside for almost 3 hours until they finally got an ambulance through the Gasparilla parade and delivered the blood. At Tampa General, it was the main teaching hospital in Tampa. There was also the development of a small hospital in South Tampa called Memorial Hospital, and that had some limited availability of certain procedures, and I didn't use that too often. So as I said, before the medical school came, which was in 1971, there had been 3 years of a certified program to teach, and so young doctors could get their degrees at that. When the medical school came in 1971, there were a lot of mistakes that they made. Amazing. And one of the first professor of psychiatry that was in charge at the medical school had a very impressive background, and he graduated from Johns Hopkins, and he was had a very good background. Well, it turned out that he wasn't a very good practicing physician. And so he would often, very often, be 2 hours late to keep an appointment to see a patient. That was true at St. Joseph's and well at Tampa General. Well, after that went on a number of times at St. Joseph, Sister finally told him, "You no longer can come to St. Joseph's Hospital. You're missing your appointments 2 hours so frequently, and there have been so many complaints." He continued to be able to come to Tampa General. And it's interesting that he uh, uh, he later in his career, he wrote a book that was about the scandals at the medical school. And the book was privately printed, and it listed a number of scandals. I won't go into those. I knew about most of those scandals, and in fact, I could add a few that he hadn't had in the book. But he was quite an interesting character. I want to tell you about going back though in time, back in the beeper stage, so to speak. The first doctor that was a specialist in physiotherapy was Dr. R. Pasick, and he had trained at Hot Springs, Arkansas, about physical therapy. And he came to Tampa to practice. And I would have a patient in a double patients there, and I'd be seeing my patient, and he would come in with an assistant and take a patient that had had a stroke and lift him out of bed and teach him, get his muscles going and so forth, where he could walk and have do other things. Before him, there was no one that really taught physical therapy in Tampa, and so patients that had stroke usually were just left in bed to deteriorate. So he was quite a pioneer. Another pioneer in Tampa was Dr. H. Mason Smith, and he was listed as a neuropsychiatrist. This was way back in maybe the 40s even, and he became a very good friend actually. Got to know him quite well, and my mother suffered from depression, and she would see him, and his treatment for depression at that time was the patient was to come in once a week and get an injection of calcium intravenously. And what did the calcium do? Well, there was a feeling of warmth that the patient would have. And so they felt good for about a half hour or whatever. But anyway, he nevertheless, in some ways, were quite progressive. And he recognized that needed some psychiatrists in Tampa. And he had he arranged for two psychiatrists to come join him in practice. And also, he got the first neurosurgeon to come to Tampa. That was Dr. Troop. And Dr. Troop was quite interesting. He got a lot of publicity because he removed a tumor from a gorilla. And that was one of his claims to fame when he first came to Tampa. And there was another neurosurgeon, I can't remember his name, but he also came to Tampa, and they did not get along very well. But nevertheless, they would cover for one another on weekends. So Dr. Kubrick and also the doctor, I can't remember the name, they were the first two neurosurgeons in Tampa, and I got to know both of them. And so, at any rate, in the computer age, we had they began to form specialty groups. There were people that the retina specialists, the on and on, different specialties, of course, hematology, oncology particularly. And so that was part of the increase of knowledge and the use of computer knowledge that was and it played an important role. So I also became, when the medical school first began, I said, wow, that's a good opportunity for me to do some teaching. So I signed up and I became an associate professor of medicine. And I would donate 1 month a year to go to the VA and give some instruction to students that already had their medical degree, but they were just beginning additional knowledge by practicing at the VA. I had an opportunity in my life to meet a lot of famous people in the field of science. Murat mentioned Alexander Fleming, the one man that discovered penicillin. Well, I got to know briefly Sir Alexander Fleming. He came to lecture in Lausanne and made himself very available for a couple of days to allow students and so forth to talk to him. And I don't know if you know, it took quite a number of years. Murat will have that information, but how long it took to take the little specimen from the petri dish of the penicillin to develop it from an industrial standpoint took many years. And when they first were able to produce penicillin in industrial size quantity, guess what it was used for? Well, it was used to take care of the gonorrhea that developed in our troops in North Africa during the war. Kind of an interesting first usage of the industrial use of penicillin. And then I got to meet a number of famous physicians over the years, which I enjoyed that opportunity. And I got very interested in some of the British physicians because they wrote textbooks that were very, very good. My favorite specialist in hepatology and liver disease was a British physician, and she wrote a wonderful book about the practice of hepatology. I also was very fortunate. I'd been in practice just about 2 years, and I got invited by the British Royal Society of Medicine. They had decided to offer, they took 15 physicians throughout the world, and they could come to England, to London, and spend 6 weeks, go to all the major hospitals there and get to hear lectures from some of the best professors in the respective fields. And that was a great experience for me. And I had to get coverage of my limited practice at that time to cover the 6 weeks. But there was only one other American physician that was selected besides myself. But I got to meet physicians from all over the world there to some extent. I had some interesting conversations with two Egyptian gastroenterologists, and they told me some of the problems that they had. So at any rate, that's a quick survey of my history in medicine, because I don't want to take up all the time from Virat. But I will tell you that I got interested in what is happening in medicine since my retirement, but even before, and that's pseudoscience. And it's a big problem. In fact, the Mayo Clinic
excuse me, Joel, I think Mary has a question. If you want to take a minute to answer the question, Mary, please go ahead.
Yeah. Let me stop then and open it up to to anyone that has some questions.
Okay, Mary, please go ahead.
Anyone want to ask me any particular questions about some of the things that I said, or questions they had about medical practice in Tampa going back to the 1960s up to the present time? Because I'm on both sides of the fence now. I'm a patient, and so I can look at things a little differently also about medicine now.
Okay.
Anyone have any questions they want to ask?
Yeah, Mary, go ahead now.
She's not muted.
Yeah, we can't hear you, Mary.
She's not, Mary, check down in the left-hand corner, the mute thing, and the little arrow that goes up, and see where your computer is sending your sound from.
Yeah, because according to
Also
me,
check on the keyboard.
Yeah, keyboard might be muted, yeah, because we can see your lips moving, but we can't hear you. Yeah, so there is some glitch. Okay, we can come back, I think, okay, Kevin, I think you were next. Yeah,
Yeah, Joel, you made a remark kind of early on about the fact that there's so much knowledge that there has to be subspecialties of all the specialties, just because you can't know everything. Do you think the average physician these days knows more than the average physician when you started practicing 50 years ago or so?
I'm sorry, would you repeat that?
Do you think the average physician has broader medical knowledge than the physicians of 50 years ago? Or are they just so specialized that they can't do that?
Yes, absolutely. And then, general practitioners. I want to just mention a little bit about general practitioners who can be wonderful people that get to know their patients well and so forth. But one of the important things for general practitioners or any physician is to know when to refer to get another opinion. And Maimonides, who was a physician in the 13th century, he had been physician to the king of Egypt and then Spain and so forth, Maimonides. And he said, one of the first things that one must learn is when to say, I do not know, which is still important for all physicians.
Okay. Thanks, Joe.
Yeah.
Jay has a question.
Yeah, when you have the opportunity, Joel, I would like to hear what you wanted to say about pseudoscience, pseudomedicine.
Yes. Okay. Yeah, it's a particular interest of mine for a number of reasons. There is a wonderful book out that's simply called Pseudoscience. It goes into this in great detail, but it's amazing. But I don't know if you can see this booklet that I got. It's from Mayo Clinic, and the Mayo Clinic says Guide to Interactive Medicine. And it's about the Mayo Clinic getting into pseudoscience. I mean, I read this book with just absolute amazement. And of course, if you get massage, that feels good for about a half hour, but it doesn't really solve any muscle problems that you have. Well, one of the things that Mayo has now is before you have anesthesia, for example, they recommend that you get a massage. And of course, these are very profitable procedures that they have. Ollie has gotten into pseudoscience and has had several courses by people that were practice pseudoscience. The new term for that is integrative medicine. And what are they integrating into medicine? Well, they're integrating what used to be called alternative medicine. There were other names for that. But I think that really it's important to have this subject discussed in some detail. And I hope that there will be better editing, so to speak, as far as selections of people that want to give courses at Ollie. Yeah. So it's an interesting topic. And if you want to read in some great length, but it's a wonderful book, it's just called Pseudoscience, and it gets into a discussion of all of this.
Okay, all right. Anybody else, for Dr. Joel, or, or do you have any more that you want to add, Joel, or before we switch over, or take a break, or whatever works for you?
Well, I just wanted to say what you mentioned, Joel, about really the most important thing for a physician to know is to know what they don't know. And
Oh,
absolutely.
Absolutely. Absolutely. And also another book that you might look at, it's written for the public. It's by a man by the name of Jerome Grootman, who's also, he's an oncologist and in Boston, and he has written several books. He's a professor of oncology at Harvard, and he has written a couple of books that are somewhat related to this. One of the books that I really like is called How Doctors Think, and it's written for the layman, and that's the title of the book, How Doctors Think. He was not the only one to write a book on that subject, but I thought his book was very up to date and quite interesting. And if I had time for another course or whatever, I could get into the discussion of how doctors think, the study that he made. And his wife is a physician as well. They have different views about the practice of medicine, by the way, he and his wife. He is a oncologist that I would say doesn't know when to stop as far as the chemo. And his wife is much more conservative in that regard. And they voice their differences of opinion and support their different views. So it's quite interesting.
Okay, anyone else? Yeah, I think so. Otherwise, please go ahead, because. All right, I think, I don't know, it's like people want to take a break now, or do you want me to start with my monologue, soliloquy, whatever we want to call slides, whatever should we call it? What's the general consensus? Or if anybody has any, I'm sorry?
Go ahead and start.
Okay, all right, okay, I'll start, let me go ahead with the share screen type of thing. Okay, share screen 2, optimize for video. Okay, I think you should be able to see my slide now. Yes, please let me know if you can see the slide.
Yes, it's fine. It's perfect.
Okay, all right, good. Okay, so now this is the final session. So we're going to talk mostly on the U.S. healthcare. We talked about the advances, to ad nauseum, the major advances from antibiotics to organ replacement and and genetics and things. But there's the things that you learn about. I read the computer magazine, and on a regular basis, when I'm taking a shower. But there's even a biosensor for urine. So you can put a biosensor in your urine, so it will check you for your diet and other stuff. So we are getting into really a huge big data type of thing, And there is also an app that you can go for premenstrual symptoms. At the same time, the genomic advances are taking place. There's a big conference right now in Oxford about the genomics and ethics. So they are saying about how to do the germline editing. And even just right hot off the press, there's a new cholesterol lowering drug, which is lowers the cholesterol by 60%, But that was administered by intravenous, and you had to go to your doctors for once a month, and it was an expensive proposition. But now it is going to be investigated in phase 2 trial for oral use. So the advances are still coming in rapidly, and there's no way any ordinary physician can take place of it. And Kevin addressed the question of teaching that made me think like how the teaching has changed dramatically. Because when we went through that, we went through the first 1.5 years, anatomy, physiology, biochemistry, statistics. Second year, we did pathology and pharmacology. And at the same time, we were introduced how to do take history and physical examination. And final year, we studied medicine, obstetrics, gynecology, surgery, and we're rotating through. So that's how it was done. When I talk to my niece and nephew, how this thing done is they do based on system. So all of a sudden they will study nephrology. So they'll start from anatomy, physiology to pharmacology and treatment. Now, what I might bugs my mind as to how can you know how to treat when you don't even know how to examine a patient properly about the complications of kidney transplant. I mean, but that's the way the system-wise teaching. And then we are done with kidney, you're done, you move on to heart. So you won't get into heart until you graduate. So that's, it just, but that's apparently that's what the trend is for teaching. So, and I don't know what other physicians think about, but I think you're not quite ready to absorb all the facts, about cardiac transplant or rejection therapy when you don't even know, as to what the heart blood supply is. But there you have it, but I'm sure there are wiser brains who thought that it was the correct way to teaching. Just made me think about how, I was just shaking my head as to how when my niece told me, said, oh yeah, we are doing gastroenterology, and then we won't touch it until we graduate. So anyway, so I've repeated some of the slides, which, because sometimes, that this is how we are the outliers for the cost, okay, and how we have, we have made strides in terms of providing coverage with the affordable healthcare, but we still have at least 10% of people who don't have care. That's why they go to the emergency room. In turn, it reflects the hospitals are obliged to provide the treatment, and that reflects in your and my premiums, especially. So that's one of the things, and that was the book that we used, in terms of, and the rise that you can see is just exponential. And some of the graphs that is extrapolated to the US healthcare cost by 2040 will be spending nearly 40% of our GDP on healthcare if this is not addressed. So, and again, we talked about the three big players. All of us are guilty, starting with hospitals. We talked about, in the name of charity, they spend about 10% or 15% for charity, and they get totally tax deductible. So hospitals are big business with coding and CEOs, and again, they claim for training, but the residents are being utilized to the max, so much so they're resorting to the union. So we talked about this role of physicians, okay, and the phrase that I just printed in a slide this morning was salva lucrum, means we are all guilty of seeing how much can we earn, and we talked about Elizabeth Rosenthal's book, which was The American Sickness, as how some of the plastic surgeons' bills are as high as, wait for it, 110,000 for repairing a wound type thing. And some of the assisting neurosurgeons, she talks about, were charging in 5 digits, And not only that, they had the audacity to sue the patient because they are out of network, so they could charge whatever they want. And it just boggles my mind that there is no way we, like and we would always write off, says, okay, this is, and I have a story about my partner that, he said, oh, you had an unpaid bill by office manager. So he said, oh, write it off. He wasn't well dressed, and they were writing it off. But at the same time, our office manager sent a letter. At the same time, a total check came from the farmer. Okay, so we're telling Lou, wait until the patient asks for discount. So it was one of those things that So it's just, oh, he wasn't well dressed, type thing. So just write off everything, But at the same time, the guy was obviously, he was a rich farmer, So just appearances can be deceptive. So, and again, the one doctor for the price of two, and the anesthesiologists were the most guilty of all. They would be going from room to room supervising 4 anesthesia. And they're doing heart surgery, which was once the patient is on bypass, they didn't have a whole lot to do. I mean, they're reading, the newspaper, so to speak. So, and again, they were double bill type of thing. And we talked about how the medicine has become monetized to a dramatic extent, and the maldistribution. And a lot of the doctors says that is a free independent provider is a thing of the past. Most of the doctors are employed by the hospital. And I have a slide to talk about the hospital corporation as to how Optum is the big money maker for United Healthcare. Okay, so we talked about other stuff, and okay, and now this is, I will send this PDF out about the healthcare, the dissatisfaction. I have the usual magazines next to me. Time magazine is an article as to how many 40% of Americans are unhappy with the healthcare. And one woman at the statement, I mean, I get a better, more affectionate care from my veterinarian than from my physicians. First of all, you spend an average of 10 to 12 minutes, okay, and you're ordered expensive tests with outlying bills. And at the same time, with the electronic health record, physicians are looking at the screen and not making eye contact or not touching. So that is the big rundown that has occurred type of thing. So, okay, so it's a long wait, short disappointments. And at the same time, this was the headline, the current headlines that we went through. Americans, the medical tourism has increased dramatically. So much so then, at the same way, people are going all the way to India and Thailand from Europe for healthcare. I think so. It's medical tourism is a big business. It's like, I mean, I have some friends who still practice in India. It's like, in Bombay, a lot of rich Arabs come and stay in the hospital because that's where the super rich go to UK. But the others are coming to India and during the monsoon season and getting medical care. Okay, and the NPR had the article as to how the medical debt still affects millions of people. So this is just straight up the headlines from the recent newspapers type of thing. And this PDF is, I mean, for the sake of time, I shan't click onto it, but it tells about the winter or the year of discontent, and especially this has increased dramatically after COVID. All right, so moving right along. Now, again, and these are the problems that are outlined, type of thing is to, and right, all the factors are guilty. We talked about the hospitals, the drugs, the complications, and the advance of technology, As I had mentioned earlier, that we are the victims of our own success, We were sent people say, oh, he's a young 90-year-old, and sometimes, being cynical, I used to say we can make him an old 90 in 24 hours, And again, it comes down to this question of society. What is the value in healthcare type of thing as to what is the quality versus quantity type of thing as to, I mean, you may get with advanced chemotherapy extra, 3 months, but at what extent, So, and I think, like in cardiology, we've been lucky that we've had a more success than other specialties, but it feels, with the oncology went through the dark years of oncology where we were giving 5 to 6 drugs and, people would have, horrendous toxicity to their heart, to their kidneys, or even their skin would get sloughed. We had to administer a chemotherapy drug called, adriamycin, and if that leaked through the skin, you'd get sloughing totally. Your arm would get big ulcer. So it was an Italian medicine. So the treatment has its own problems type thing. And I shall have a couple of slides about overdiagnosis. All right, moving right along. This is the thing we like to congratulate ourselves, but you can see as to how we say, oh, the streptomycin was the big breakthrough for tuberculosis, the scourge of the industrial age and of humanity. But you can see that the incidence of tuberculosis had decreased already dramatically before streptomycin came around. Perhaps because people's nutrition improved. I mean, we can't say that the crowding had decreased because there was a lot of industrial. This was right after Industrial Revolution, and you can see how crowding was in Western Europe and even in this thing. But the incidence had increased, so there is no logical explanation unless other people, the bacteria become less virulent, people develop subclinical immunity or what have you. So this is still an enigma as to why this happened. At the same time, there are two things. So the infections we talked about, inheritance we can't do much about, but the biggest problem that we have had is the affluent society. This is the chart that we talked about for obesity. This is for moderate obesity. This is for massive obesity. I shall see if I can zoom in on that. This is severe obesity, and from 1990 onwards, and we talked about how, the American Heart Association and the cholesterol hypothesis, we just had kind of we went off a little bit on the wrong tangent by cutting back on the fat, but we increased the simple carbohydrates and sugars, and that explains as to how we are awash in this epidemics of obesity. Okay, and then again, wait for it, we have a treatment. This is this week's Economist, the new drug, the injectable drug. Okay, Bruce Gobioff, who is, I don't think he's joined us yet today, but he's talked about ChatGPT. But this is on the medical side. This is the GLP-1. This is the enzyme that is brought to it stimulates your insulin. You pee out a lot of sugar, and these are the new wonder drugs. They are so much so they're in short supply, and the Hollywood celebrity is using it for weight reduction. So this is, and the economists, they're into how the investment goes. The market for these new drugs is going to be $180 billion over the next 5 years. It's going to be overtake all the cancer drugs that are around. Okay, all right, and this is from none other than Bernie Sanders when he was talking about the drug prices. And this is, okay, some of the drugs you may be familiar with: EpiPen, which is for injectable therapy; Crestor is cholesterol drug; Premarin, a lot of women know about. Abilify is a treatment for depression. I think if I had to pay $2,600, I think I would be more depressed for the price than for anything else. And Januvia is the new diabetic drug, which is, again, like you can see how it is 5 times more than in Canada across the border. At the same time, the biggest mistake that we did when Part D was included in Medicare, but they lost the ability to negotiate the prices. So that was, we threw away the whole baby with the basket, so to speak. So these are some just examples. That is just, and again, this does not include the new biological drugs, which are, like in 5 digits. We're talking about some of the drugs. Okay, and again, we have, this I promised I would include some slide. Okay, so, and how the medical, like this was a symposium that was done in Korea when they had overdiagnosing thyroid disease. So some of the Australian researchers took their type thing. So this is, I just put in the slides a couple of days ago. Some care is good, so screening for disease, type of thing, and as to how we're taking out, and the classic example that a lot of the men know about, how the screening for prostate cancer. If all men live to be 80 and 90, almost all of them are guaranteed they'll get some type of prostate. If they do multiple prostate biopsies, they'll find cancer in most of them, but won't necessarily be fatal. And we talked about it in the class of mini medical school as to how, managing cancer rather than trying to cure is the trend that is being evaluated now. Okay, and getting a medical test can't hurt, but obviously, we talked about the radiation with CAT scanning and other stuff. And obviously, some of the tests that are not painful are being overutilized. The Joel gave an example of electrocardiogram prior to simple biopsy. But wait for that, you'll get a complete echocardiogram, which costs anywhere from, the charge can vary anywhere from $300 to $1,200. And I've seen that. Our hospital charge in Green Bay was like at the most $200 or $300. Some of the East Coast hospital would charge as much as $1,200 for an echo. And if you don't have symptoms, you really don't need one. And the same way for preoperative screening. Okay, people were sent around for cardiac screening, and people will end up having a bypass surgery beforehand so that they can have knee replacement. Okay, and there is clearly no data that it makes a difference. Okay, so this is, and again, in cardiology, we were all guilty type of thing as to how treating the anatomy rather than physiology was the big thing. So the 3 tests that you see at the bottom, computerized scanning, carotid ultrasound, and I talked about earlier about screening at churches and looking for disease and taking advantage of the sort of gullible, population in underserved areas. Okay, saying that, oh, these are the doctors who are offering screening. So that is the big scam that goes on. Okay, and so this is somewhere along the line we need to put a brake on overdiagnosis and overtreatment. Okay, and again, by lowering the criteria, we've added 13 million people. This physician named Dr. Welch, who is a Canadian internist, talked about a lot about overdiagnosis and overtreatment. So these are some of his slides. By lowering the criteria for blood pressure, we added 13 million people. Same way by tightening the hemoglobin A1C criteria or blood sugar, we've added. And I talked earlier that some of the long-term trials did not show that we were improving the morbidity. Same way for cholesterol, we've added a number of people. Now finally, just to be fair, the pendulum is swinging to the more stable side. I see the clock is up to 11 o'clock, so perhaps people want to take a break. I will stop my monologue and meet in another about 10 minutes or so, perhaps, if that makes sense. now type of thing. And let's see if I'm okay. Let's see, share screen. Let's start all over again. So okay, you should be able to see my slide, hopefully. All right. Okay, please let me know if you can see the slide.
Yes.
Okay, good, thank you. All right, we should go on. So we talked about as to how we've increased the criteria for treatment. And again, we are the most successful species. You can see how the cost has increased type of thing, so because, we are, everybody, even in the so-called, developing countries, the lifespan has increased, So Malthus was wrong, because we have dramatically, we have the most successful species, like how over the last, 70 or 80 or 100 years almost, So no wonder type thing, And we come up against, see the red line? I showed this slide on my aging class, just thought it was humorous enough as to worth putting it again, as to how, biologically, we are fighting against Darwinian evolution. Mother Nature does not want you to live after you have had children or grandchildren, type of thing. And we are pushing the envelopes. We are seeing great grandchildren. So I know and things wear out. And when we did the class on, and there is a big moment as to seeing classifying aging as disease. So if you can get that, accomplished, there are some interesting work that is being done by a guy named David Sinclair, who's an Australian researcher at Harvard. And, they're working on various vitamins. There's a trial being done on metformin, the good old diabetic drug for aging. And if that looks positive, it would be a whole dramatic shift in how aging takes place. And we talked about how we are dealing with obesity. So again, the big thinking in science, the reductionism, it is paying off. I mean, you cannot say that, like the reductionist science has improved the cholesterol treatment and the other things, have dramatically. So, so there is big dramatic progress that being made now. And these are some of the books that I've referred to, and these are just few of these things that I've referred to. America's Sickness. I already talked about Hofferdized, Marty McCarry's part. Less is more. This is the Canadian internist who is talking about the overdiagnosis. And the last red one is an Irish gastroenterologist about can medicine be cured. At Rich Kennedy's Social, we talked about Emmanuel Ezekiel's book, and last but not the least, the digital medicine guru from cardiology, he has switched to digital medicine, Dr. Eric Topol. He's a very erudite speaker on how to integrate modern, genomic medicine into science. So he has written in a very positive way. So these are some of the references that people with more time can read. And this is again another slide type of thing. And I think the upper right-hand corner you can't see very well, but I will just read them out. We are, how much wastage we are doing. Starting from fraud at 75 billion. Prevention failures 55 billion. Okay, inflated prices 105 billion. Okay, inefficient delivery of the care 130 billion. So it's just unnecessary services cost 210 billion. So it's just it's a dramatic numbers that these are staggering type of thing. And even the wealthiest country, which is not necessarily United States, but I mean even Switzerland and Singapore or Kuwait may have difficulty affording this care. So 8 out of 10 workers have chronic conditions because we are living longer. No wonder we have more chronic conditions. As Mother Nature did not program us. So the numbers are your condition critical. That's are the serious articles in all the journals that you'd see type of thing now. Okay, and so and a lot of that. As many as 100 million people have some type of healthcare debt. This was just yesterday in NPR. This as up hot off the press, type of thing. And Medicare's spending grew up 8.4% in 2021, or 21% of this thing. So we are, the numbers are just going up and up, so somewhere along the line, we're going to reach a breaking point. And it talks about, now this is the big thing about, like I talked earlier about, I learned the word about pharmacy benefit managers, PBMs, So this is a complicated network that talks about how so many actors are involved. Oh, sorry, let's see if I can zoom in, like going from patient, as to how much the drug would cost, and how much the manufacturers would get, how much the wholesalers would get, how much the pharmacies would get. But look at this category, pharmacy benefit manager. These are the middle level men who negotiate the contracts, and they make out more than the actual pharmacy would. And obviously you are at a cost for copay type of thing. So, and this was, and the saga that occurred a few years ago about the EpiPen, which is the injection for allergic reaction. It's a life-saving drug, and the price jumped dramatically from $100 to $600, and that is, and that with rebates to pharmacy benefit manager, the cost is $608. Without rebates, is $300. But an equivalent drug that is marketed, that is $110 at CVS. On the other hand, a small pharmaceutical, a boutique pharmaceutical company has marketed the same drug at $4,500. Basically same, sustained release adrenaline. So it just goes to show how dramatic things the market change is. Okay. And similarly, this again shows the gross profit, the revenue between the manufacturers, gross profit, and how much the pharmacy benefit managers would take off the top. So the changes, the price, and this was a series of articles in 2017 in Wall Street Journal. And if you can figure this out, how this chain works, see how many actors are involved, payment product, vendors, manufacturers, the chain is dramatically complicated how third-party payers. And obviously the worst is the one who are the self-pay pocket out of it. Okay, there is another slide, about the pharmacy benefit managers. Okay, let's review that. These are some of the well-known common drugs. Some of these are generic, lisinopril, a common blood pressure drug, antidepressant drug, a cholesterol drug. But the middle column is how much the pharmacy benefit managers that go. This is the light gray color. Yeah, you can see how much they are making out from a $600 drug. So it's it's a dramatic shift that takes place as to how there is no way you can find out how much the price is. And sometimes it happens that the cash price is cheaper than what your insurance is paying. That just blows my mind. Now this is a rather elaborate slide, which is really hard to see, but for sake of time, I'm not going to go over that. But these are the varieties of policy measures that are proposed type of thing at the global level versus the national level. And there's a physician level, I think I remember that one study was done that one hospital, just for a short time, they started putting price of each and every drug that the doctor wrote, and it changed the practice dramatically. A lot of times, we had no knowledge as to how much the drug was costing type thing. Okay. And unless there are some new ones, type thing. And the same way, the prices are, the transparency, at least United States, there is no way of knowing how much the test would cost at 2 miles from the hospital. A different hospital would have a totally different price. So that is just something that we have to go around. But it's not all bad. There is some silver lining, and you can see that the current administration is proposing some guidelines for negotiating prices. Hopefully one can see that at least about 15 or 20 drugs they are trying to negotiate. It may take up to like they're starting out with very baby steps of 10 drugs of Part D, and then 15, and so on and so forth. And and in the current proposed budget, and we finally saw some lightning that even the regular customers would be paying $35 for insulin. And at the same time, some of the other states are passing new laws for consumer protections that the hospitals would be obliged to give more financial aid to people with limited resources. And also the credit card companies are finally saying that they would stop including the medical debt on your credit account. So you won't at least lower your score, so you can't get a loan for buying a car. Okay, so there is some silver lining. This is, the Kaiser Foundation slide. Okay, let's see. I think somebody had in the chat. Yes, yeah, Kevin. Yeah, we talked about it, Kevin. Absolutely, Ziki, Emmanuel, and we had a very stimulating discussion about why I want to die at age 75. And I think it's it obviously he wasn't quite 75, so he may change his opinion. No, thank you for sharing that. Okay, so all right, so moving right along. So there is some silver lining that is occurring, that at least your credit would not be ruined, just because you are behind in the pay, or paying on installment type of thing. Okay, and so this is a rehash of the same thing I already alluded to type thing as to how much debt there is, Okay, and some of these measures were passed, in predominantly democratic leaning states, and to be fair, two more right-leaning states, Arkansas and Idaho, passed measures that would extend the time during which creditor could collect some medical debts, type of thing. So, and New Mexico law requires hospitals to screen patients whether they qualify for free or discounted care. So various states are making some states type of thing, but still there are some, predatory hospitals, which we talked about in smaller towns. And the charity hospitals are not about suing the patient and garnishing the wages. Okay. And again, this was thanks to Peter pointed this out to me earlier, type of thing as to how the fraud is occurring in the publish and perish struggles in medicine. Okay. This was an article not in the current issue of Economist, but in your as to, this is staggering as to how many papers are being retracted. And during COVID, the numbers increased exponentially as to how some of the trials that were done, and obviously the one that comes to mind was the ivermectin, that the papers were actually withdrawn, type of thing. And there are some of the countries that is definitely suspected fraud, plagiarism, and the data is misinterpreted. And some of the biological data was very hard to interpret because, you're looking at billions of letters of genomic analysis, and especially looking at some, a Western blot that is a method to see how the genomic sequences can form. So some of this data is spudged and actually downright fraudulent. And the round of the usual suspect, a lot of the retractions were done from China, Russia, Iran, Malaysia, Egypt, India, and yes, US was not above it, that thing. And the Brits were low down on the list to give them credit type of thing, so that the retraction rate was. But again, they have the classic example, the anti-vaxxer, Dr. Wakefield, who started the link between the vaccination and autism that has created the biggest backlash and gave ammunition to the anti-vax community, and the promoter on MTV, Jenny McCarthy, she was the big spokesman and really increased the anti-vax, crowd to the max. Okay, and again, the medical errors, this is almost hard to believe type of thing that the malpractice causes more than 250,000 deaths. Okay, that is, so, and the awards, the malpractice awards, 1 in 14 are $2 million. Okay, and we're the town which has Morgan. So, and the two specialties which are neurosurgery and OBGYN, which stands to this thing. Okay, and the most common errors were retained foreign objects during surgery, operating on the wrong part. Okay, and the birth injuries, because every woman wants to have a perfect Einstein, and again, labor and delivery is risky. We are fighting Darwinian evolution, basically. Okay, that you're going to have a breech presentation. Sometimes, there is going to be a error that a matter of minutes. That's why, call a midwife, becomes a risky proposition sometimes, Okay, and that's one of the reasons why the increased incidence of cesarean section. And I told about earlier about how some doctors use the catchphrase of "it is good for the baby," and do more cesarean sections, And so this is a failure to diagnose. Okay, and maloccurrence is not malpractice. That's the biggest fundamental problem. So, things are going to happen. Medicine is not a perfect science by any means. So that's where we stumbled upon it. I think so. Okay, so this is one of the things. Again, when we talk, I already had given the example of bypass surgery outcomes. How some of the bad surgeons actually retired when they were pointed out, because no hospital wants adverse publicity on the local news channel. So that improved the practice. And this is a good example that I may have alluded to, but I just worth repeating that the famous Michael DeBakey, who was a vascular surgeon, he was almost like 85 or 90 years old, who was invited to operate on the Shah of Iran. I think he had some pancreatic problems or gallbladder problems. And considering that, he did not need to put in the drain. He did not put in the drain during the surgery because he was not, I don't nick the pancreas. During removal of spleen, it's likely the spleen is so close to tail of pancreas that you could injure pancreas, and if the pancreatic juice leaks in the stomach, that is some horrendous consequences. And lo and behold, that did happen. Okay, and the Shah of Iran, suffered for almost a month, and finally they called some French surgeon and drained almost a gallon of pus. So it just goes to show as to how, why did they call him? Because he had not done a splenectomy for at least 30, 40 years, but he had the big name. And when I saw that when he was 90 years old and he was called for bypass surgery of Boris Yeltsin, I was just like, they couldn't find somebody else who was younger and more experienced? But there you have it. And he himself was a good example. He had discovered the surgery for aneurysm. He was a pioneer of that back in the early 60s. And when he was 90 plus years old, he had the same problem. Initially, he turned down surgery and later decided to go ahead with surgery. After being in the hospital for 8 months, it cost $1 million. I think he eventually passed away. So that's the story about how overdoing and overtreatment and incompetence occurs at the highest levels. Okay. So just because you're at Johns Hopkins does not mean you won't run into bad surgeon. And I'm sure that happens at all hospitals. And all of us who are in the field would tell you, I would even send my dog to this doctor. And I'm sure Joel can tell you stories about it, and so can all the physicians. There is an inside knowledge, but the code of silence that is there, which is something to be frowned upon. Okay, all right. And so how to choose a doctor, that is difficult, because some doctors have a personality of a peapod, while the others have great hands, And so this is so we have already talked about, how the ads and getting around. Okay, but I won't belabor the point. And again, this was a cartoon that was worth sharing. Aging doctors, that somewhere along the line, there was a few weeks ago, I think we had discussed an article. Would you go to a doctor who is 95 years old? I probably wouldn't, because when I did a colonoscopy, I was able to get an appointment with a doctor very quickly. And when I looked at him, he was 83. And I said, come on now, give me a break. So I just wisely canceled and finally was able to find a physician in Zephyr Hill. Couldn't get an appointment with anybody in Green Bay. In Tampa, rather. So that just shows the story. That's how difficult it is to get into access care. Okay. And this was the history of timeline of this thing. So it goes back to time of Teddy Roosevelt that care has been now and this is I can't go into that because this is a whole PDF that which let's see if I can open it. Okay, and I would have to stop this share and start a new share basically. Okay, this is an interesting thing from Kaiser Foundation. This is a very nice PDF that at your time, it goes back to 1900 from Teddy Roosevelt's time to FDR, who proposed. Hopefully people can see the screen about the timeline of healthcare reforms in the United States, during the Depression, when the early start of Blue Cross that started in Texas, when the teachers were offered insurance for $5 a month and were guaranteed 24 days. That was the start of nonprofit Blue Cross Blue Shield. And again, unfortunately, that was not included in your taxes. It was considered as a fringe benefit. So the labor was opposed to it. And then FDR had proposed, but again, the big fear of socialism was always the bigaboo that the more conservative and the AMA raised that flag and defeated, the Times. Joel probably, he may be just starting practice at that time, but Truman proposed that, and the AMA had the huge campaign. And then again, the whole system changed with Medicare and Medicare in 65. So this is a nice timeline that you can just read through. It goes year by year from the Great Society and the invention of Medicare and Medicare and the other acts that were passed, and the varieties of attempts and the failed attempt of Bill Clinton to the last things of affordable care or quote unquote Obamacare. So I will stop this screen share. Let's see if I can go back to my second thing. Okay, so this is a nice or very quickly talk to you about the healthcare in the United States. Let me minimize this. Okay, yeah, we're in business. And obviously the Obamacare model was based on the Romney, Massachusetts care. Okay, and that has made an impact type of thing. And in spite of attempts at repealing the care, it has still become the law of the land. All right, so, okay, and this is again some of the slides, I think this was Harry Truman's statement. and the big fear that they had raised of the so-called socialist medicine. Okay. And again, how much do the administrators make out? Now, this slide is almost this thing, that some of the salaries of the CEOs of Tenet Healthcare, which is a big corporation which owns for-profit hospitals, $21 million. Okay, and some of the other salaries, and even the nonprofit salaries, the CEO's salaries are, in the millions. So, I mean, and they're not even coaching the football team for the hospital. So the numbers are just, if they were, that's a different story. So this is called Fierce Pharma, and that has a variety of. It's an interesting website. It's called Fierce Pharma, Fierce Insurance, and Fierce Healthcare. So I think it's a commercial website, but they have some interesting data for those who are interested in pursuing things. Okay, and again, these are some of the big giants. The United Healthcare, started by a physician named Bill McGuire, and who was guilty of stock option fraud, that thing, and paid some horrendous fines. And again, the Hospital Corporation of America, this is the yellow things, which is our honorable senator was took the 5th number of times. Okay, and so this was, and at the same time, when he was the governor, he vehemently refused to expand Medicare under Affordable Health Care Act. Okay, so and we already talked about the charge master and the CPT codes. I mean, there are 5. This is the CPT with the charge master code. There are 5 codes for simple laceration. So depending upon how you play the coding game, you can increase your billing. And this is, the older slide, but it shows the expansion of the, Hospital Corporation of America, starting from the 70s onward, how the revenues have gone on an exponential basis. Okay, and again, this is a flow chart of how healthcare is delivered in the United States. Okay, I mean, majority of people, we don't complain because we have private health insurance, either through employers or through a military or something. Public health, for over 65 people are covered, but those first are those who are uninsured, because they are the ones who pay through the nose and they pay the official charges. So this is, and we're coming up to like 12,000. Okay, and a word or two about the lobbying, so the 70% increase in 20 years. Big Pharma spends 216, insurance 121, hospitals 74, and I'm sure AMA is right behind there. In the various specialty societies, they all have lobbies. And in terms of medications, Americans filled 4.5 billion prescriptions in 2016. That is nearly double that of 97. Now, does that make you think that did we get more sick in 20 years? I should think not. Okay, so I think, and the Medicare Advantage. Okay, so now there is the big push that is being done for expanding the Medicare Advantage type of thing. But it's again, there are some associations of physicians who are really saying that this is actually a big profit-making business that is coming up, type of thing, as to their with the risk adjustment and this bonuses and the coding system that they are getting, as to how there was one example that was given was like for a simple surgery that for which the Medicare would pay with the normal coding of $9,000 by adding comorbidities such as morbid obesity, depression, chronic lung disease, pressure ulcer. A simple payment can be increased from 9,000 to, by upcoding things, to 32,000, based on something called the risk score. So these private insurance companies, have learned to game the system, and so the original Medicare ends up paying billions of dollars more to these big corporations. So much so that even the hedge fund industry is interested in getting into this game. So that's one of the things, because I have a family member who is big into the medical administration and the AMA. So that is the big thing that is coming about, to how even that this is such a lucrative market that they are thinking about investing into that. That is, and obviously those who follow the stock market, how some of the best talks are the ones for the healthcare company. Okay, let me see what the chat thing was. Yes, Bismarck was absolutely the first one with the state, right? Yeah, you're spot on. Yes, exactly type thing. So yeah, he was ahead of the time. And I think, and I think, sorry to say, but I think UK was far behind in covering this, and you can share if you want to take time about making statements about the NHS, type of thing, that it is hated and liked type of thing, both. Okay. And part of the problem is because the population is getting older and the technology is becoming more complex. So, and what was valid budget for 1970 is no longer valid for 2020. Okay. Yeah. All right. So we're moving right along. We have a few more slides, but I think some of the ones that I will gloss over basically. Okay. All right. I think I'm going to pass over this. And the trust has eroded type of thing. And this was a survey that, for those of you who are seeing my attachments, this was the survey that was done from trust as to how the trust has deteriorated among. And physicians don't trust some of the other physicians. They don't trust some of the ancillary things. So the game goes both ways, and the public has distrust for a lot of it. So somewhere along the line, this goes back. These are some of the old axioms, that goes back to the classical Enlightenment age. See if I can zoom in, from none other than Voltaire. In amusing the patient by nature cures the disease. But I think, respectfully disagree. We've come a long way since then. Perhaps too long, but too successful. And the art of medicine is love. There is also love for humanity. And that goes back, to Hippocrates' era. And we seem to have forgotten that, obviously. I talked about Abraham Verghese earlier, who teaches physical diagnosis at Stanford. Okay. All the risk, it's inherently risky when you're dealing with the biological entity type of thing. So, okay. And so these are some of the statements which are pretty self-explanatory, and I shan't dwell too much into it. Okay. And again, we have lost the art of listening type of thing, the history and physical that Joel talked about, the Osler, who was one of the four giants at Johns Hopkins when the medical education was streamlined finally after the Flexner report in the United States. So that was the big dramatic change that took place, when a lot of the schools were closed. Now, I shall defer with this thing because there is perhaps, we as physicians, we need to leave with open mind. The reason is people are reaching out because we seem to have failed, but the reductionist approach has, we have paid far less attention to patients' social condition, their nutrition, and the other stuff. So there may be something to be said about it may be a placebo therapy, but the reason because there is a demand from the public, and some of the big institutions are just reacting to it, So unlike Joel, I would respectfully defer that, there may be some of the big institutions are reacting to the demand from the patient, because they're, that we're seeing that there is some other data that is done about the usefulness of quote unquote alternative medical therapy type of thing, that, and obviously the Chinese are big into it. I'm not going to show the slide, but there's a huge slide that was published right now from the traditional Chinese medicine, that they're trying to see if there is any scientific basis to the old quote unquote therapy. And they always like to tout the big therapy for artemisinin, which was the drug for malaria that Chairman Mao had suggested that they should look at it. And Madam Tu, who actually worked diligently for about 20 years and isolated the active ingredient of the Chinese traditional medicine. And that was a big breakthrough in malaria therapy. Okay. And again, I would give you an example that I think Dr. Gerald Stulk, who's did a history of medicine class that some of you may have attended, he's going to be coming here on April 18th. And his talk is going to be, medicine's fundamental roots type of thing. And just to give an example, that in Indian Ayurvedic medicine, there was a medicine that was promoted, which was called Sarpagandha, means it kills the snake type of thing. And that medicine was based on, and that was used as the first medicine, antihypertensive therapy in 1949 by an Indian cardiologist named Dr. Vakil in BMJ, in British Medical Journal. And Siba Gaigi, this was just a letter to the editor that he had proposed. Ciba-Geigy followed up on it and isolated the active ingredient of the drug, which was one of the first drugs that was isolated for treatment of blood pressure, called reserpine. And there was the early days of blood pressure therapy. So, and obviously, and at that time, when he had proposed the article, but the gentleman did not patent the drug, so they did not, I think that was one of the earliest start that was done. So that is, one can say that one cannot completely knock, type thing. And these are various slides, so the slide is this thing. But so you can't just say that we can close completely our mind to this thing. And this goes down to the philosophy of Eastern versus Western way of looking at it. It's opposed to the reductionist approach, which we have adopted since the Enlightenment, versus holistic approach, I think. And that, and since are some of the medical myths, which you can just see that, which are pretty, I just threw in, as to how we have some of the wrong beliefs that we have carried out. And the primary care physician, is like the rest in peace, the internist, the freestanding internist who was a consultant is a thing of the past, type of thing. So instead of consultant and providing a variety of scholarly opinion on illnesses, we have become healthcare providers. And the varieties of acronyms that are touted about the general practice, where people had 1 year of training, with the family practice, to the nurse practitioner, to the physician's assistant we studied after the Vietnam War. And now almost 50% of physicians work as hospitalists. And so this is, and so from doctors, we have become proceduralists, we talked about earlier, type of thing, And this is, I gave you the example of how various subspecialists, they do not want to provide any direct care. All the care is channeled through the hospitalists. Again, duplicating services, and increasing the billing. So you can see the chart of the growth of a new industry, those hospitalists who do not know the patient. So, and the biggest problem that people have is they cannot see their own doctor who knows them very well. Okay, when they go to you meet a totally new person, and the communication between the hospitalist and the primary care is totally lacking. Okay, and again, the same way the general surgeon had, has also, we have to feel sorry for the general surgeon, because their thing is being taken over. The gastroenterologists and the endoscopists have taken over the ulcer surgery. At the back, the hysterectomy is taken over by the gynecologist. That's oncological surgeons. So you have to feel sorry for the general surgeon. They are used to trauma and appendix, and even that is being treated with antibiotic. Okay, so it's and the same thing has happened in cardiac surgery, that the cardiologists have taken over a lot of business. Just the other day, there was an article about replacing the right-sided heart valves with catheter alone. So the tricuspid valve, which was very difficult to replace because it's a thin walled chamber. So that is, the average age of cardiac surgery is 49 plus, and 8% of cardiac surgeons are older than 40. Because nobody wants to spend those 7 years training when their workload is to number of bypasses have gone down. Okay, so that is that's one of the things. And the new medical graduates are choosing for the so-called lucrative specialties such as emergency medicine, anesthesia, dermatology, radiology. Those are the easy testing. And the big rise of interventional radiology, where they can really do some dramatic things, like treating strokes with catheters. Okay, there was an article a few days ago about endovascular thrombectomy for stroke in the New York Times medicine section. Again, the evidence-based medicine, that was the big thing that was proposed by a physician named Gordon Guyatt at McMaster University. And this was the concept of scientific medicine based on, really the gold standard of double-blind studies, that was proposed, and that was the big rise of evidence-based medicine that the American College of Physicians promoted. And okay, let me see the chat. Exceptionally low, yes. They seem, having seen the work, yeah, absolutely. I think. Further to Joe's comment, it's important to know what you don't know. I think I should say that litigation fear is probably over promoted by physicians. If you sit down and talk to the patient, get to know them, and if you admit that, didn't turn out well, but we ended up hitting the carotid artery while trying to, put in an intravenous line. It happens, I mean, type thing. So most patients are forgiving type of thing. And, like somehow, either the Midwest culture or other stuff, there weren't that many suits that were done, that we just didn't see that much, obviously. So the communication is a big fault type of thing. Obviously, I understand some specialties are very high risk type of thing. And also, there are some physicians who really deserve to be sued type of thing. Okay, they're, I mean, one incidents come to my mind that we knew that person had, had tears in the esophagus, but he continued to operate on him. And obviously the patient got a rip-roaring infection of the chest cavity. And, the surgeon deserved to be sued because he totally missed the diagnosis type of thing and did not pay attention to the simple common sense. So the evidence-based medicine, that's the big thrust that started in the 90s, and the treatment guidelines for almost all the diseases started being published, that thing. And there's a Cochrane Institute started in the 70s, okay? And that was, they were putting some vigorous criteria showing as to how the particular treatment guidelines are successful or not, I think so, okay? And so some of the data, it's analyzing the data with various strong statistical means is being done. And that has made some impact as to, and again, the American College of Physicians is also making some attempts at choosing wisely. These are the guidelines that are published for those of you who are interested, that thing. So, okay. Let's see. And this is the level of evidence, for all the major illnesses, one can find evidence through College of Physicians and College of Cardiology, and similarly for gastroenterology as to how whether there is a level 1 evidence, level 2 evidence. This is just basically isolated case report, which people used to go based on their gut feeling, so to speak. Okay, and again, this is double-blind study trial. Okay, so these are the varieties of evidence that people should try to follow, and that does improve the outcomes, type thing. So, okay, I mean, the usual thing is like physicians would say, in my experience, that means they've treated 1 case. In my series, that means they've treated 2 cases. I've treated a number of patients. That means they've treated 3. Okay, so that's that thing has again fallen by the wayside, that thing. And again, the data explosion. There are almost like 900,000 papers that are published. So we are awash in data, and the information that is available doubles every 72 days. So no way anybody can keep up with this thing. But some of the fingertips, like well, we used to carry something called a physician's handbook of treatment in our pocket, or Washington manual in our pocket. I'm sure Joan remembers that very well. We carried in our white coat pocket, called Washington manual, that had a simple what test to order and how to treat. It was very easy reference book. But nowadays, people just, all the medical students, they don't have to memorize this thing. They can just look it up on Google or through the up-to-date guidelines. And so they have a lot more access available even in the field, Okay, and this is again the evidence-based guidelines, but then again, it's sometimes a gut feeling goes a long way in terms of just following the treatment guidelines. And I give you the example as to whether to change the intravenous lines every 3 days in a 90-year-old, does it make it worthwhile? Okay? And to cause a lot of misery. So it becomes a problem. So sometimes that it doesn't always work out to the best of our ability. And we already talked about the Medicare Advantage, as to either it's neither Medicare nor Advantage, one can say type thing, because there are sometimes restrictions that are done. And okay, let's see what we have here. We're getting close to 12 o'clock, and we already talked about how the report card of physicians from patients is, we're getting a dismal C- basically when we take general survey. I think so. In spite of our, patting ourselves on the back, we are not doing so great. So there is a real crisis that we are facing. Okay, and again, so these are, we should have spent a lot more time, but I think we don't have time to discuss, how avoiding death as to which is part of life. And I had invited our other friend, Alex Lerner, but I don't think he has joined us here so far, because I think he had other commitments. But I think, we can just open up as to how, how the fear of death, death definition was devised by the Harvard committee that included, finally when the cardiopulmonary resuscitation became available, how the definition of brain death with organ donation came to available. And again, we in society, we have the varieties of trade-off. On one hand, we, restrict speed and other stuff. At the same time, we undertake more risky behavior such as boxing and football. Okay. And then again, the big trend that has become in some of the Western European countries about physician-assisted suicide. Okay. There are varieties of definition that are put about euthanasia, physician, all of us remember Dr. Kevorkian, 10 minutes. Kevorkian's case, who was, who was sent to prison for assisting, and he was kind of a rebel, against the system, but that is becoming more and more a norm, and some of the Western states are accepting physician-assisted suicide. Okay, and the Lancet, they're ahead of the curve, and they had appointed a commission on death type of thing. And this is a video, but there is a link here, but I don't think I'm going to, for sake of time, I'm not going to show it. Okay, a couple of more slides, and then we should be done. And this is, letting go. Atul Gawande, who is the ENT surgeon, he has written a very thought-provoking book about being mortal, about his own family's death, the type of thing. Okay, all right. And so, and there's a PBS series, and the Frontline had done a program on it also, about having the difficult conversation during the last days of life type of thing. And varieties of physicians have written their own personal experiences about, death and dying. Okay, and these are some of the famous people who talked about during their last days. Christopher Hitchens, who was dying of esophageal cancer. Susan Sontag, who had a blood cancer, wrote about the illnesses as a metaphor. Stephen Jay Gould, who had a mesothelioma, and he talked about the median is not the message, because he had some advanced cancer, and the average statistics was pretty dismal. But he thought, well, he would be an outlier, and sure enough, he was. And Kevin already alluded to about Emmanuel Ezekiel's article about those things. So this is the varieties of famous people who talked about death and dying type thing. So okay, and Canada has a rather vigorous program. So this was the data that you can interpret in whichever way you like as to how scheduled to die. And it may be that some of the families may be pressuring this thing. So Canadian provinces, 5% of deaths are medically assisted deaths type of thing. So Quebec had like 4.7%. Okay, British Columbia 4.8%. Okay, and progressive Vancouver Island was unofficially known as the assisted death capital of the world. So that again, so there may be some more this thing than we realize. So we may be getting down a more slippery pathway.
My name is Dr. Susan Rogers, and I'm a general internist from Chicago, Illinois, and I'm president of Physicians for a National Health Program, which is a national organization of more than 24,000 doctors that advocates for a single-payer healthcare system. And I am also a proud beneficiary of traditional Medicare. The current threat to Medicare is very real. What we now call traditional Medicare was created in 1965 to provide a safety net for seniors and the disabled, many of whom lived in poverty, and to provide equity in healthcare when it effectively desegregated our nation's hospitals. Today, even though it is the most popular, effective, and efficient health program in our nation's history, traditional Medicare is at risk of being sold off to the highest bidder, with no input from seniors, health providers, or even members from Congress. Now, the privatization of Medicare began when Nixon enacted the HMO Act in 1973, and privatization actually exploded in 2003 with the creation of Medicare Advantage, the version of Medicare run by commercial insurers. The common thread among these privatization experiments is the theory that inserting a middleman between Medicare and its health providers, between physicians and patients, will somehow save money or improve care. However, it has failed at both. In fact, researchers estimate that Medicare overpaid Medicare Advantage insurers by more than $106 billion from 2010 through 2019. And that's money that could have been spent on seniors' care. Despite decades of failure, CMS launched a new model of Medicare privatization called the direct contracting. And instead of paying doctors directly, Medicare pays third-party middlemen called direct contracting entities, or DCEs, a set amount to manage seniors' health. DCEs are then allowed to pocket what they don't pay for in services, which is a dangerous financial incentive to restrict and ration seniors' health care. If you haven't heard of direct contracting, that's by design. It was created in 2019 by the CMS Innovation Center, also called CMMI, which is authorized to conduct payment experiments and scale them up to all of Medicare without input from Congress. Virtually any type of company can apply to be a DCE, including commercial insurers, venture capitalists, or physician groups. Seniors in traditional Medicare can be automatically assigned to a DCE without their knowledge or understanding if their primary care provider is affiliated with a DCE. Then the only way for a senior to opt out is to change primary care physicians, making this actually a bait and switch program for seniors. Forcing seniors to switch physicians is not only a terrible burden, but it undermines the importance of the patient-physician relationship that clearly DCEs don't acknowledge. The new model program that DCE middlemen will somehow lower costs and improve coordination of care. But former CMS and CMMI officials estimate that DCEs may spend as little as 60% of their Medicare payments on patient care, keeping the other 40% as profit and overhead. How this is an improvement on traditional Medicare, I don't know, since Medicare spends 98% of its funds on health care. As a physician, I understand that it is my duty and responsibility to help make the care decisions along with my patients and then coordinate that care. That role is not for investors to take from us. They do not coordinate care, they coordinate payment. Medicare was designed as a lifeline for American seniors and adults living with disability. We cannot let it become a playground for Wall Street investors. If middlemen in healthcare actually save money and improve outcomes, the U.S. wouldn't have the most expensive and ineffective healthcare system in the world. We don't need to put seniors through another failed experiment to prove this. So like an old African proverb says, if you keep doing what you've been doing, you'll keep getting what you already got. So we need to get back to what we know works, and that is traditional Medicare.
Okay.
My name is Dr.
Okay, I think so. This was worthwhile, right? Now I think before we end, I have to ask, at least Joanne, as starting out as a woman physician, as to what type of discrimination she faced when she was entering the male bastion of medical society. I think, Joanne, if you want to share whatever your experience was as a medical student, as to see whether you thought that you were being treated as a second-class citizen or what have you. Just jump in. I would like to hear from you, type of thing. So,
I was sort of a Pollyanna. I think I had a way of avoiding the thought, and it wasn't until later that I recognized some things that had happened. But in my medical class, there were 6 women and 120 men. And then a few years later, when I was in the emergency department, and we had students from Jefferson Medical School, and there were 4 women in one group. And I said, I can't believe there's 4 women in one group. And they said, we've never had a woman attending. So it was different. But there were some things, I think in academia and so on, there were things you sort of instinctively knew you couldn't get to. But I loved practicing medicine.
No, actually, yeah, because I think, we have, as we have a personal tale, I think, because in Green Bay, there were only 2 women anesthesiologists, my wife and another, Asian Indian woman anesthesiologist. And when the other people decided to form a group, they did not invite these 2 women to join the group. Okay. And, and in fact, there were a couple of other physicians who had actually history of substance abuse and said, oh yeah, we'll welcome them in the group. So it was, and the same thing, it's like how, and we had a woman cardiologist with us, and she was always used to get, Sarah would always get mad. Oh, you are the nurse, I mean, the stereotype, they just continue, while we had a male nurse and he would say, oh, this doctor stayed with me all night. I mean, how many times I've heard this, and George Bennett was a good nurse. He would always tell when he came on at 10 o'clock at night, I'm George, the male nurse. But next morning I say, oh, this doctor stayed with me all night. So the stereotype amongst patients was just unreal as to how they would address Sarah by the first name, while they would address me as Dr. Pathogen. So it was, it was an interesting thing, paradigm on the patient's part as well as the other physician's part, type of thing. So, and
There was a long time when people just didn't recognize that you were a physician. Because of your lab coat, the stethoscope, the
I
sign,
think,
everything.
fortunately, it has changed now with the 50% of medical school class. I mean, there are women urologists, and so obviously there is a wider acceptance type of thing. So, and sometimes, I don't know how this little 130-pound women become orthopedic surgeons. I think now that's because orthopedic is a very physically demanding thing. So, okay, I think we are almost running out of time, and now, and last but not the least, this is the videos that I put from Frontline, which are long videos, links for those who want to see. They do an excellent job about American healthcare crisis. Okay, this was again critical care. This is Frontline PBS NewsHour. Okay, and these are the full video type things. And I eliminated the one from Yes Minister about about the British healthcare system, where they have administrators but no patients. And I think Peter would love to see that. I think there will be, sometimes I can't put it on the copyright because then Google would let you upload it to YouTube. So okay, I think we're done. I should stop my screen share and stick around for questions, comments. I think
Peter had a question or a
oh
comment.
yes, please.
So I was just going two things. One, I've stuck in the chat. When Terry was in medical school, she was told by a fellow student that she was taking a place from a male student,